Acetaminophen Paracetamole Overdose from Ministry of Health Pocket Manual in Emergency from Saudi Arabia Ministry of Health. So, toxicity in adult is likely to occur after single ingestion of greater than 150 milligram per kg or 10 gram over a 24-hour period. Single ingestion of greater than 150 milligram per kg or 10 gram over a 24-hour of period. The progression of liver disease after acute acetaminophen ingestion. The stage, approximate duration, the description, result of lab test, and manifestation. So, stage 1 is from 0 to 24 hours. Description, preclinical injury phase, the result of lab normal or increase the AST in severe poisoning. The manifestation, asymptomatic or mild non-specific symptom as nausea, vomiting, anorexia, and malaise. So stage 1, the first 24 hours, the preclinical phase, the lab test may be normal or there is increase in AST in severe poisoning. The symptom may asymptomatic or mild non-specific symptom as nausea, vomiting, anorexia, and malaise. The stage 2, from 24 to 72 hours, the onset of liver injury. The lab test increase ALT and HAST, increase bilirubin, increase prothrombin, increase lactate, increase phosphate, and creatinine. Nausea and vomiting and right upper quadrant pain in manifestation. So stage 2, between 24 to 72, the phase is onset of liver injury. The lab test, increase liver function test, increase creatinine and lactate phosphate. The manifestation, nausea, vomiting, right upper quadrant pain. The stage 3, from 72 to 96 hours, is the maximal hepatotoxicity. There is increase in liver function test and ETN, increase in creatinine and ammonia. There is in manifestation, jaundice, coagulation effects, hypoglycemia, renal failure, encephalopathy, and coma, MSOF. Stage 4, from day 5 to day 7, it is recovery phase. Then the test normalization. Then the manifestation, complete resolution of hepatotoxicity. Clinical presentation, history, the dose and time of ingestion, formulation of ingestion, the pattern of use, single doses or repeated doses, the duration, so the dose, the time, the formulation, the pattern, duration, concomitant ingestion, intent of use, is suicidal or for analgesia, history of trauma, coexisting illnesses, the witness and family members, history of liver injury or alcoholism. The physical examination, ABCs, heart should be monitored for dysrhythmia. Tachycardia may suggest congestion of sympathomimetic or anticholinergic agent, dehydration, blood loss, pain, agitation. Tachypnea may indicate metabolic acidosis, respiratory alkalosis, or hypoxia. Abdomen to detect the pain and hepatic enlargement. Mental status, which could suggest encephalopathy. The pupils examination. Scan, evidence of depression, suicidal attempts, psychiatric illnesses. The differential diagnosis, ascending cholangitis, biliary disease, hepatorenal syndrome, ascending cholangitis, biliary disease, hepatorenal syndrome, hypercalcemia, ischemic hepatitis, shock liver, fulminant viral hepatitis, pancreatitis, perforated viscous, Ray's syndrome, toxin-induced hepatic failure as mushroom toxicity, and other toxins. So, differential diagnosis, ascending cholangitis, biliary disease, and hepatorenal syndrome, hypercalcemia and ischemic hepatitis and fulminant viral hepatitis, pancreatitis, perforated viscous, and Ray's syndrome, and toxin-induced hepatic failure as mushroom toxicity, amatox, and other toxins. The workup. Obtain a blood paracetamol level at the 4 hours after ingestion. In patients who have a toxic level, follow up serum testing 12 to 24 hours after the first result. A serum concentration drawn between 4 and 24 hours after an isolated ingestion should be plotted on the Romac methyl nomogram. Complete blood count, liver function test, serum lipase concentration, urine analysis, toxicology panel, and Romac methyl nomogram, coagulation studies, chemistry panel, and other blood work, pregnancy test, echocardiography, HET, CT. Then the management, pre-hospital, assess amounts of the congestion and any congestion, evidence of a trauma, vital signs monitoring, cardiac and pulse oximetry, and administration, supplemental oxygen, plasma glucose concentration, obtained patient should be intubated, suspected suicidal attempt or intentional poisoning by a third party, the patient should be brought to emergency for evaluation and treatment regardless of amount ingested. In hospital care, activated charcoal up to 1 hour after ingestion, administer antidotal therapy in acetylcysteine as the loading dose is 140 milligrams per kg, followed every 4 hours by additional doses of 70 milligrams per kg to total of 17 doses. Treat fulminant hepatic failure. So, activated charcoal up to 1 hour, just 1 hour after ingestion. Administer antidotal therapy in acetylcysteine as the loading dose 140 milligrams per kg, followed by every 4 hours by additional dose of 70 milligrams per kg to total of 17 doses, and treat the fulminant hepatic failure. Refer the patient for urgent liver transplant if criteria are met. Provide supportive and appropriate follow-up care. Control nausea and vomiting. Manage renal dysfunction. Admission. Monitor and treat hypoglycemia, vitamin K, and fresh frozen plasma for coagulopathy. The disposition. If the level is not toxic with normal AST lethal patient, is at minimal risk for toxicity, and treatment with N-acetyl acetate is not indicated, can be given medical clearance and a psychiatric evaluation. At discharge, patient should be instructed to return immediately if symptoms of hepatic injury arise as abdominal pain or vomiting, hepatotoxicity, renal dysfunction, or multi-system organ involvement, admission to ICU. Thank you.